Hello class, I'm going to begin this online lecture with week 2, day 1. Our concept is elimination, and our exemplar, first of all, is urinary incontinence. And I just want to go over a little bit of the reading before we begin going over the PowerPoint that we have here for you. Just to know what urinary incontinence is. Just want to, first of all, start with explaining that urinary incontinence is not part of the aging process, okay? It is an involuntary urination, and it is a symptom and not as a disease. And it's probably one of the most common manifestations of impaired bladder control. And of course, depending on the degree as to which a person has urinary incontinence, it can really affect quality of life as well. It can create physical problems such as skin breakdown, and it can lead to a lot of psychosocial problems, including embarrassment, isolation, and really not able to cope with the problem very well. And of course, causing someone to become socially isolated and socially withdrawn. I thought this was important. It gave some statistics about urinary incontinence in your book. It's estimated to be between 10 million and 13 million individuals in the United States and 200 million individuals worldwide that suffer from this problem. The estimated annual cost of managing urinary incontinence in the United States is about $16.3 billion, 75% of which is spent on treating women. And although urinary incontinence is especially common among older adults, it is not a normal consequence of aging, and it can be treated. An estimated 30% or more of older women living in the community experience urinary incontinence. And in long-term care, assisted living, and homebound populations, the incidence is between 50% and 80%. And even though we know of these statistics, the actual prevalence of urinary incontinence is nearly impossible to determine because people don't confess or admit that they have this problem because, of course, they're quite embarrassed. And the availability of products to protect clothing and prevent detection contribute to patients not seeking evaluation and treatment for incontinence. And we see this type of advertisement all the time on the television, especially for women that experience this type of problem of urinary incontinence. So let's go over the PowerPoint. This is uploaded in your Canvas course as well. And when we think about urinary incontinence, it is about one's privacy and, of course, their modesty. And a lot of people do have a difficulty confessing and bringing this problem to light, to discuss it and look for ways in which urinary incontinence can be treated. A lot of people have difficulty discussing genitals. The testing and examination can be quite embarrassing for some women. Fear of bodily changes. And interventions can be provided for the individual. And sometimes it is necessary that extensive testing be done to consider and to kind of know the extent into which someone is incontinent. And sometimes it's also important to look into the etiology of why someone is suffering from such manifestations of urinary incontinence. So that's why some of these quite uncomfortable diagnostic procedures need to be done. But there are primary preventions. Early detection is important, and of course management for the problem is out there. It's just bringing it to a light, to a head, to make it known that the problem exists, and then to do something about it. So again, what is urinary incontinence? It's an involuntary urination. Just like I said, it's a symptom and not a disease. Most common manifestation of impaired bladder control. And to make it extremely stressing the point that it is not a normal consequence of aging, okay? 30% of older women experience it, 50 to 80% in long-term care, foster care, and homebound populations, okay? Just stating those facts that I just went over with you. Why does this happen? This talks about the pathophysiology and the etiology of why someone becomes urinary incontinent. Results from higher than normal bladder pressures or reduced urethral resistance. And these are some of the contributing factors: relaxation of pelvic musculature, disruption of cerebral nervous system control, and disturbances of bladder and its musculature. And your book does give a brief explanation about urinary control, that when you do urinate, it does require a bladder that is able to expand and contract, and also sphincters that can maintain a urethral pressure higher than that of the bladder. And of course, with incontinence, that's all changed. The incontinence results when the pressure within that urinary bladder exceeds that urethral resistance, allowing, unfortunately, for that urine to escape. And any condition causing higher than normal bladder pressure or reduced urethral resistance can result in incontinence. And your book talks about 3 examples of conditions that can cause higher than normal bladder pressures. And the first one is the increased volume of urine in the bladder from use of diuretics. We see that very often with our patients who are on medications to help them urinate more frequently and to get rid of some of that vascular volume. The growing size of the uterus during pregnancy that puts pressure on the bladder. That's a number 2 reason why we see higher than normal bladder pressures. And 3 could be from a weakened urethral sphincter relating to decreasing levels of estrogen during menopause. And so relaxation of that pelvic muscle, disruption of control related to cerebral or neuronal dysfunction, and disturbances of the bladder and its musculature are also common contributing factors. Okay? And so we'll look at other reasons why incontinence happens. And incontinence may be either an acute or a self-limited disorder, or it can also be a chronic problem, all right? And it can also be congenital or acquired, reversible, or irreversible. And we talk about urinary incontinence being acute and reversible when it is associated with either a partial or a complete resolution to the problem. And up here on the screen, I do have some examples of when urinary incontinence can be reversible. And some of these examples of reversible reasons why someone develops urinary incontinence is polyuria, in which there is a large amount of urine that's being produced, exposure to irritants, urinary retention, constipation, and restricted mobility. And other reversible conditions that cause urinary incontinence may be from psychological conditions, delirium, and medications such as diuretics and sedatives, or even a UTI. That's one of the most obvious manifestations or sign or symptoms of a UTI is when someone becomes incontinent because they might have urgency or irritation to the bladder as well. Now the following, starting with this slide, are irreversible examples of urinary incontinence, and they can be any kind of central nervous system problem, spinal cord trauma, stroke, multiple sclerosis, or Parkinson's disease. And a couple other examples are epispadias and meningeomyelocele. And epispadias is when there is the absence of that upper wall of the urethra. And when we talk about a meningeomyelocele, it's a neural tube defect in which a portion of the spinal cord and its surrounding meninges protrudes from the vertebral column when there hasn't been total closure during fetal development. Now we talk about risk factors. Who is more at risk for developing urinary incontinence? And it would be obviously the older you get, the more chance you are for developing urinary incontinence. Women more likely than men. People that are homebound or live in a long-term care facility. Obesity, people who smoke, diabetics, inactive people who kind of are not as mobile as they used to be, pregnancy, depression, neurological disorders, and certain medications, which we've somewhat touched upon as well. Now these are ways in which we can prevent urinary incontinence. Lifestyle modification. And what we mean by that is obviously maintaining a healthy weight, eating a diet that is high in fiber that can help prevent constipation, which definitely is a risk factor as we talked about earlier. Avoiding bladder irritants, and what we mean by irritants is people who drink a lot of alcohol or have foods that are very acidic or spicy foods. Can also help prevent urinary incontinence. And drinking adequate fluid, but not excessively. And what this means is should not drink less than 6 to 8 ounce glasses of water daily. And likewise, if someone would drink a lot of water or too much, it can lead to rapid bladder filling and consequent urinary incontinence. And other preventative measures include getting regular exercise, not smoking, reviewing medication, and reducing physical barriers to toileting for patients that are at high risk, that kind of have those problems with functional ability. And these are what we see manifest with a patient and what kind of symptoms we see with someone who develops urinary incontinence. Inability to avoid urinating, increased rate of urination, they start having leakage problems, uncontrollable wetting, and frequent bladder infections. Now we can get very specific when we talk about urinary incontinence, and we can kind of label what type of incontinence someone may be experiencing. And these are the different types of incontinence: stress incontinence, urge incontinence, reflux urinary incontinence, overflow incontinence, and functional incontinence. And I'll go over these in detail to kind of explain what each one of those kind of demonstrates or kind of manifest. And just remember too that we do have some people that may experience more than one kind of incontinences. And probably the two most frequent incontinences that particularly women experience are both stress and stress and urge incontinence. So I'll go over those and explain those, what each of them mean. Now there is a table on page 314 in your Pearson Concepts book that specifically talks about each of these types of urinary incontinences and looks at the etiology, the clinical manifestations, and what types of clinical therapies are provided to the person who does develop these type of problems. And the first one is stress incontinence, and that's probably one of the most frequent types of incontinence that someone may be experiencing. And this is when there is a relaxation of the pelvic muscles and weakness of the urethra, and the surrounding muscles and tissues lead to decreased urethral resistance. The pelvic muscles are weak, and we see this happen to a lot of women who, experience multiple vaginal bursts, where those pelvic muscles begin to weaken, and also for women that go through menopause and, of course, have a decreased amounts of some of their female hormones, which also weaken those muscles as well. You might see someone develop stress incontinence when they sneeze, when they cough, maybe they laugh, or maybe they kind of turn their bodies kind of quickly, and before you know it, they're leaking out urine, okay? The clinical manifestations of this is loss of a small amount of urine when sneezing, coughing, or lifting, uncontrollable wetting, weakness of those urethra and pelvic muscles, and increased pressure on the bladder from pregnancy, obesity, a cystocele, or erythrocele. And depending on the severity of the stress incontinence will determine if it can be treated medically, where you might see Kegel exercises, which are those pelvic floor exercises. We might advise someone who, when they're out in public or they're out socially, might advise them to wear some type of absorbent pad or diaper. There's also urethral inserts, Passeri devices, and sometimes medication might be very helpful, as well as, if it's very severe, surgical repair, especially if we're talking about a structural problem like a cystocele or a erythrocele. So that's stress incontinence. The next one is urge incontinence, and this is the condition that results from a hypertonic or overactive detressor muscle, leading to increased pressure within the bladder and inability to inhibit voiding. No matter how much urine, it might be just a small amount. This is that commercial that you see on TV that says, gotta go, gotta go, gotta go, and you just absolutely have no control over the bladder function and you just urinate. It is an involuntary loss of urine associated with a strong urge to void, increased rate of urination, inability to avoid urinating until a bathroom is available, and this is where you have that overactive detressor muscle, and you also develop nocturia. You get woken up in the middle of the night, and it may not be a large amount of urine that's in the bladder, but it still causes you to get up and get that sensation that you have to urinate. There are some medications out there that you will be learning in Nursing 123 that will help with that. Again, pelvic floor exercises, behavioral modification, and again, maybe encouraging a woman to wear those adult briefs and some type of absorbent pads as well. The next one is reflux urinary incontinence. This is the condition that results from disruption to the neuronal control of the pontine and or sacral-micturition centers due to neurologic impairments of tissue or tissue damage. This is manifested as complete emptying of the bladder at a predictable bladder volume. You might see this with neurological deficits, frequency, nocturia, and inability to sense the full bladder or initiate or inhibit voiding. We see this with some types of spinal cord injuries, neuromuscular diseases, like multiple sclerosis, when there is really no bladder control or you don't sense that your bladder is filled. And we see that in a lot of spinal cord injuries as well. Clinical therapies for this is, again, medications, catheterization, possible surgery, neuromodulation, and again, absorbent pads and adult briefs, especially when people go out socially. They don't want this to occur, which could really saturate clothes and cause extreme embarrassment as well. Overflow incontinence is that condition that results from an outlet obstruction or lack of normal detrusor activity, leading to the overfilling of the bladder and increased pressure. This might be for a male person who suffers from BPH, or who has a urinary obstruction. Say, for instance, someone has a large kidney stone that has now advanced down in the ureter. There is a urinary obstruction there. The urine is not able to pass, and it could backflow back up into, it could backflow up into the kidney and cause an obstruction after the bladder becomes full. Maybe there's an obstruction in the urethra, which would cause the bladder to continuously fill up, causing then a loss of urine, okay, because the bladder has been severely overdistended. All right, and again, some of the same clinical therapies: surgery, catheterization, and some medications, and again, absorbent pads and adult briefs. And then the last one is functional incontinence, and this condition results when the ability to respond to the need to urinate is impaired, as seen in dementia, some physical disabilities in patients with impaired mobility. And I think the good example for this is a patient that does have dementia, where they might know their bladder's filling up, but they don't have the sense to say, hey, I need to use the bathroom, and they just might go wherever they're at. So we see manifestations such as loss of urine associated with physical impairments that prevent that person from reaching the toilet in time, and due to some of the cognitive deficits that they may have. So that's why for someone like this, if they're in an assisted living, or maybe they're living at home with their children or their adult children, they might just take the person to the bathroom on a regular schedule to prevent that overfilling and possible incontinence from occurring. Okay, so I hope those all make sense to you. There is a handout, I think, that we have uploaded in your Canvas course, and I'll bring that up to kind of show you how it kind of looks at these different types of incontinence. Okay, and hopefully you'll find that helpful. And this is looking at urinary incontinence across the lifespan, and also looking at the cultural considerations as well. We look at children, and the age at which a child attains urinary continence varies. Usually, as the book states, daytime incontinence is usually not diagnosed until around age 5 or 6, and nighttime incontinence is not usually diagnosed until about age 7. More than 90% of children are continent during the day by age 5, but usually it's at nighttime that they struggle with, and usually this takes a little bit longer for a child to achieve nighttime continence. Most cases of urinary incontinence in children clear up spontaneously with no treatment, but potential causes of diurnal enuresis include bladder irritability, weak detrusor muscle, constipation, structural abnormalities, sexual abuse, UTIs, and infrequent voiding. And a lot of times when kids are at school age, they voluntarily hold urine to avoid using toilets at school, or also they get very wrapped up in their play and they don't want to take the time to go to the bathroom. Nocturnal enuresis is more common than diurnal enuresis. Almost 30% of children at age 5 have some type of nighttime bedwetting. 10% at age 7 and 3% at age 12 and 1% at age 18. Nighttime enuresis is more common in boys than in girls, and although it is more prevalent in children, 0.5 to 1% of the adult population also experiences some type of nighttime or nocturnal enuresis, and there is a lack of evidence exploring nocturnal enuresis in geriatric populations. So that's a little bit of why some of these kids and even the elderly develop some kind of nocturnal enuresis. And then, of course, we know that pregnancy does affect urinary continence and may cause incontinence with the pregnant woman. This is because definitely of hormonal changes and, of course, of the excess weight that's pressing on the woman's bladder as well. And after a vaginal delivery, postpartum women may have urinary incontinence, either temporarily or long-term. And this can be due secondary to the edema from that local trauma from that area as when the woman gave birth to her baby. And it also causes weakened bladder muscles, and can be damage to the nerves and the supporting structures as well. And sometimes we see pelvic organs pushed into the vaginal area, and it prevents the urethra from closing completely. And of course, I did mention a little bit about urinary incontinence in the older adults, and probably the most common type of urinary incontinence that we do see in the older adults is functional incontinence. May be the predominant problem in older adults living in those institutions that we talked about. Limited mobility, impaired vision, dementia, lack of access to toileting facilities, and privacy are all kind of part of the problem of why these older patients do experience urinary incontinence. Tight staffing patterns increase the risk for incontinence in previously continent residents. The primary problem in functional incontinence is an outside factor that interferes with the ability to respond normally to the urge to void. Okay, and think about someone who's pretty much limited to their bed. They may wet the bed if a call bell is not within their reach, and a patient with Alzheimer's or dementia may perceive the urge to void, but he is unable to interpret its meaning or respond by seeking a bathroom, and that's how I explained it earlier. For these patients, self-care deficit in toileting is a very, very serious problem, and that's why they have this chronic problem of urinary incontinence. These are some of the non-pharmacological therapies: Kegel exercises, behavior modifications, scheduled toileting, habit training, bladder training, children, urgency containment exercises as well. And these are things that I've already discussed with you, but it's nice to kind of sum it all up and see that absorbent pads and diapers, pessary and vagina to hold up bladder, urethral insert to plug leaks, and sometimes catheterization is necessary as well. So that's a review of some of your reading, and hopefully you've been able to go over this information and, of course, understand the different types of urinary incontinence as well. All right, what I want to go over with you now is 2 case studies that have to do with urinary incontinence, and just bring to light what may occur with a elderly patient, as we're going to learn a little bit more about her. So this is Appendix 7 that's in your weekly lesson plan. So you might want to get that out and follow along with me. Mrs. Grace is a 70-year-old housewife who presents to you complaining of troubles with the bladder. She has limited her involvement in social activities following several public incidents involving incontinence and has started to wear pads. She voids 8 times a day and 5 times in the night. She complains of feeling tired and poor sleep quality because she has to get up at night to urinate. Sometimes Mrs. Grace starts to leak urine on her way to the bathroom. On further questioning, she also reveals urine loss when coughing or sneezing. She has had 3 uncomplicated vaginal deliveries. She drinks 5 cups of coffee daily and enjoys brandy before bed. Her current medical condition includes hypertension, which is well controlled, osteoarthritis, and obesity. Her current medications are amlodipine, 5 milligrams daily, diclofenac, 25 milligrams twice daily, and temazepam, 10 milligrams at bedtime. There is no history of surgery or relevant family history. On examination, Mrs. Grace is alert and interactive. Her body mass index is 31 kilograms per meter squared. Blood pressure is 130/74 millimeters of mercury, and her pulse is 70 beats per minute and regular. She is afebrile. Her gait is steady. Physical examination shows mild vaginal atrophy, positive urinary stress test, and hard stools on rectal examination. The remaining physical examination is normal. Urinalysis, blood sugar, and thyroid stimulating hormone levels are also normal. All right, so now we kind of have a good idea of this patient, Mrs. Grace. A little bit about her background and her health history, what medication she's on, and what kind of manifestation she's unfortunately experiencing. So let's look at these questions and talk about them and kind of think about the information that was presented to you on the PowerPoint and the information hopefully you retain and understand from your assigned reading as well. So let's look at question 1. Based on the symptoms that Mrs. Grace complains of, specify the types of urinary incontinence she is currently experiencing. Well, I think the one type that pretty much gives it away is in the last line of the first paragraph, where she talks about she's losing urine when she coughs or sneezes, and you all know that that is stress incontinence. But she's also experienced another kind of incontinence, which is called urge incontinence. So, as I said before, this poor lady is unfortunately experiencing 2 types of urinary incontinences. So, she's not experiencing functional because she does get the message to her brain that she has to urinate, and what she is doing is getting up and going to the bathroom to relieve herself. But you can understand why this poor thing is not feeling rested at all. First of all, she's voiding 8 times a day, and she's getting up 5 times during the night, which doesn't give her much time to get into that good, deep quality sleep that she needs. So this is really a big reason why she complains of feeling tired the next day and has poor sleep quality. All right, so list 3 possible causes of Mrs. Grace's urinary incontinence. So you want to think and go back to those risk factors that the patient has. And let's just take a couple minutes to think about what may be the reason why she's developing these problems with incontinence. Yes, first of all, she does fit the bill for many of the risk factors. She's obese. Age, she's over 70. She's drinking a lot of bladder irritants. She's drinking 5 cups of coffee a day, and caffeine is a bladder irritant. Plus, she's having a little alcohol at night. What else might you think could be another risk factor that she is experiencing? She's had 3 uncomplicated vaginal deliveries. She's obviously gone through menopause, so she's lost that protection from female hormones. And we need to take a look at her medications. Her amlodipine is a calcium channel blocker, which she uses to control her hypertension. And her diclofenac is an NSAID, which she uses probably to help with the pain she experiences with her osteoarthritis. And what that medication is, 25 milligrams twice daily, is an NSAID, or a non-steroidal type of medication, okay, an anti-inflammatory, and it does cause a reduction in urinary output and a decrease in urine concentration ability as well. Another things too that might be causing her with problems with urination, think about what temazepam does and what the action of that drug does. Now I know you're probably haven't had these medications yet, but it's important, again, as we've always said, to review the list of medications your patient is on. And the drug temazepam is a sedative. It's usually for sleep at night. We used to give it a lot to our patients on the med-surg floor. It's also known as Restorol. And that is a little bit concerning to me because some of the side effects with temazepam is it can cause muscle weakness, lack of balance, or coordination. And if Mrs. Grace is getting up that many times during the night, it really is a very serious safety issue as well, with her possibly falling. So, not sure if I'd want someone of her age who's experienced all this problems with incontinence during the middle of the night to be on a medication, and she's also on 10 milligrams as well. So those are some of the risk factors, and maybe you can think of others as well. She does have some mild vaginal atrophy, which may affect the pelvis area and bladder control, and she did have a positive urinary stress test as well. Identify any changes to Mrs. Grace's current lifestyle that may improve her urinary control. Definitely would encourage her to change how many cups of coffee that she had a day, maybe just giving herself 1 or 2 cups a day. Not sure if the brandy at night is good to take, not only for her incontinence, but also with a sedative or a sleep aid as well. Might make her very, very sleepy and cause some problems. So maybe the alcohol is causing her problems as well. Maybe drinking a little bit more water during the day. Obviously wondering if she's wearing any protective pads or underwear when she's developing, unfortunately, that stress incontinence where she's having urine loss as well. Let's see what else. Maybe change her medication for her osteoarthritis, substituting something, maybe try some Tylenol rather than the diclofenac, 25 milligrams daily, because that does affect urinary incontinence as well. Encouraging her to possibly lose some weight, encouraging a little bit more walking and exercise through the day as well. She sounds like she's in really, really good shape, except for this major problem because her urinalysis doesn't show any type of infection. Her blood sugar seems to be in good control, and she's not experiencing any type of thyroid problems as well. So those are things that we want to think about and just try to teach the patient about things that may be aggravating her incontinence, and then just to visit her doctor regularly to keep an eye on it to make sure that it's not getting worse. Maybe there is some structural problem that later on may need to be fixed surgically. So things just right now that we can do are things that I've just kind of talked about. And look back at that PowerPoint slide and go over your reading as well to see if maybe she fits into any of the other risk factors and categories of why she's developed these problems with incontinence. You know, when the patient comes to their physician or healthcare provider and opens up about this problem, because let's face it, it's not a subject that is very easy to talk about. They get a little more history about what's actually been happening with the patient, and many times diaries are important for the patient to keep to kind of get an idea of foods and fluids that are associated with problems that you're having with incontinence. Can kind of see some kind of correlation between the two. And they'll do urinalysis on the patient and some blood tests as well. But the bladder diary is a good thing for patients to start keeping track of. It records how much the patient does drink and when the patient urinates and how much urine is actually produced, and if the patient feels the urge to urinate, and how many incontinent episodes the person obviously experienced. Then it gives the healthcare provider a better idea if the patient does a good job of keeping track of this in her diary of exactly what type of incontinence the person is experiencing. And then, of course, they look at the urine itself, looking at the appearance, the color, if there's any blood, if there's any types of organisms or any type of infection in the urinary tract itself. They also look at various blood tests that may identify potential hormonal or chemical causes of incontinence, such as maybe the person has diabetes. And they also may do 24-hour urine samples, post-voiding residual measurements, and also a little more testing, more intensity to the testing by doing urodynamic testing and a stress test. They also may do x-rays to look at the structural makeup of the kidneys and the bladder. And they also may do a pelvic ultrasound, and they also may do cystography, and that uses an actual radioactive dye, which they insert into the bladder through a catheter to show any bladder abnormalities, and they also do a post-void volume as well. They also might do a cystoscopy, where they insert a cystoscope to visualize the urinary tract, and again to detect any type of or abnormalities. And they may also take a little bit of a sample from the tissues that will be sent to pathology. And then the last resort is some type of surgery that may be associated with a cystocele or a urethrosil. Okay, so those are also possibilities as well to hopefully fix the problems with urinary incontinence. All right, let's look at this second case study. Okay, this one is a little bit more involved. So part one is Mrs. Kingsley moved into Gardens on the Green Care Center this afternoon. Her husband of 54 years suffered a heart attack and died a month ago, and Mr. Kingsley was Mrs. Kingsley's primary caregiver for the last 3 years after Mrs. Kingsley had a stroke which resulted in limited mobility of the right arm and a slow gait. Mrs. Kingsley enjoys using her mind and enjoys being around other people, but she has been generally physically slower after her stroke. The Kingsleys have 3 children. The 3 adult children live out of town. They tried to coordinate home care for their mother over the last month after their father, Mr. Kingsley, died, but the care was fragmented at best. The children offered to have Mrs. Kingsley move in with them, but Mrs. Kingsley did not want to leave Evansville, the city where she grew up and where she raised her family. Mrs. Kingsley needs assistance with her activities of daily living. She needs assistance with dressings because of limited mobility in her right arm. She can feed herself on her own slowly, but does need help with meal preparations. She is able to walk with a cane, but moves slowly. Mrs. Kingsley is considered usually continent. She has approximately 1 episode of incontinence once every 3 weeks or so, simply because she cannot get to the bathroom quickly enough. Before he died, Mr. Kingsley reminded her to use the bathroom every 2 to 3 hours, and then took her to the bathroom once in the middle of the night. On her first evening at the nursing home, the certified nurse's aide, Sue, met Mrs. Kingsley. As Sue was helping Mrs. Kingsley get ready for bed, Sue set up pads on Mrs. Kingsley's bed and explained to her that she will just put the pads on her bed in case Mrs. Kingsley had an accident at night. Mrs. Kingsley was nervous because this was her first night at Gardens on the Green. She did not say anything, but she wondered why she needed these pads. After all, as long as she went to the bathroom once during the night before 3 a.m., she never had a problem with accidents, as Sue called them. She did not want to seem like a pest and asked too many questions on her first night. Sue's charge nurse did not suggest that she wake Mrs. Kingsley at night. Therefore, Sue was just doing what she knew to do. The next morning, Sue was gone, and another certified nurse's assistant named Kelsey was helping Mrs. Kingsley get dressed and asked her to wear a Depends just in case she could not get to the bathroom in time. The charge nurse was busy, and Kelsey did not receive any other instructions about Mrs. Kingsley's toileting habits. Kelsey did not ask her if Mrs. Kingsley wanted to wear the Depends and did not ask her about her bathroom habits. Mrs. Kingsley wanted to talk about it, but Kelsey seemed rushed, and Mrs. Kingsley did not want to bother on her first day. After Kelsey left the room, Mrs. Kingsley sat and cried softly. So you can see what a problem this is for this poor patient. It's really very sad, in which the staff are trying to do a good job for this patient, but are not really looking at what are the real problems and what can I specifically do for this patient to make her feel comfortable and well at ease with the situation that's occurring. Okay, we kind of learned a little bit about her history. She has had a stroke. Her husband did help her a lot with her toileting, but right now these 2 certified nursing assistants are just handling everybody in the same way. They see her as an elderly patient, so they figure she's probably incontinent, so they're already putting chucks all over the bed and making that patient feel like, well, they're expected to be incontinent in their bed. So look at these questions, and I'm not sure if I have the perfect answer for each of them, but it does give us something to think about where we need to look at the individual needs of each of our patients that we're caring for. And I realize that this lady is in an assisted living where it's not really in an acute care facility, but still I understand the short staffing and that they do have a lot of patients to care for and to be sure that they're all safe. But still, I just feel like Mrs. Kingsley really never had an opportunity to say what works for her. So question 1 is, how do you handle urinary incontinence with new residents who move into your nursing home? And I think first of all, we need to talk to the patient and ask them what they want, what they feel they need to be in a comfortable environment and not feel embarrassed by anything that may happen. And I think, how can we improve dialogue with residents on the topic of urinary incontinence? I think it's a difficult situation, but I think we have to be honest. And I think we can subtly ask, do you need help or assistance to get to the bathroom? And do you need any type of pads or anything like that? If you don't, that's good, but also to know a little bit more about the health history of our patients and to know what unfortunately is occurring, especially in their toileting habits. It's a very big part of a patient's everyday lifestyle. And we do know that obviously she fits the bill with many of the risk factors, but like I said, this is not a normal process or a normal problem of aging, so we can't assume that every elderly person is incontinent. And part 2 is a month later, the same routine continued with Mrs. Kingsley. She used pads on her bed at night and wore Depends during the day. She was no longer usually continent. She was now classified as occasionally incontinent, having a few episodes of incontinence each week. And her husband was no longer around to remind her to use the restroom, and it was hard for the nurse's aides to remember to remind her. So Mrs. Kingsley was very self-conscious about her incontinence episodes and wanted to stay in her room close to the bathroom in case she had to use the bathroom. As a result, she was not attending activities and she was showing signs of depression. Mrs. Kingsley felt helpless. And again, this is a big problem because, as you can see, now it's causing her to develop social isolation, depression, and this isn't good. And this incontinence will probably just continue to get worse. From the story, we only know some basic information on Mrs. Kingsley's continence patterns. What type of incontinence could Mrs. Kingsley have, and explain your thought process? And what kind of toileting program could you suggest in order to help Mrs. Kingsley? And how would this type of toileting and program impact Mrs. Kingsley's quality of life? Well, if we got her on a regular schedule and we encouraged her to go to the restroom or reminded her just like her husband did, she would have felt comfortable, she would have relieved herself and could go out and socialize with other people in the facility. And how would it impact your quality of life as a caregiver? Well, if you have less patients becoming incontinent, there wouldn't be the changing of linens, and plus you would develop a better relationship with your residents as well, and develop a trusting relationship with them. And it would also give the both of you the ability to be able to share personal stories or be honest with each other, so that could also affect your workload as well if you were one of the caretakers or caregivers of these patients in an assisted living. So we got to look at each person as an individual and not assume that everybody has the same problems or treats the problem in the same way as well. All right, so I hope you found both of those very helpful. And what we're going to do now is just go over some of the questions and answers for urinary incontinence. All right, let's look at question 1. The nurse identifies which of the following as a high priority goal for a patient with stress incontinence. Look over the 4 choices. Identifies products for protecting clothes and furniture. States chronic and benign nature of the disorder. Performs pelvic floor muscle exercises twice a day. And limits intake of beverages with artificial sweeteners. And I'm sure you all chose number 3, performs pelvic floor muscle exercises twice a day. And that's one of the suggested clinical therapies for someone that has stress incontinence. Good job, everyone, and here's the rationale behind it. It should not be viewed as a normal aging process, but rather as a treatable problem. Pelvic floor muscle exercises strengthen perineal muscles, increasing urinary sphincter control, and will reduce the incidence of incontinence. Artificial sweeteners have been identified as a bladder irritant contributing to urge incontinence, but have less impact on stress incontinence. It is not a nursing priority to help the client to protect clothes and furniture or to have the client state the cause of the disease. The priority is addressing physiological needs. Question 2. For a client with flaccid bladder, the nurse is most likely to teach which of the following. And when we talk about flaccid bladder, that means when the bladder just really doesn't have a lot of tone to it, and so it just kind of is very limp and is very difficult to control as well. And the choices are habit training, attempt voiding at specific time periods, bladder training, delay voiding according to a pre-scheduled timetable, and Crede maneuver, apply gentle manual pressure to the lower abdomen, and 4 Kegel exercises, contract the pelvic muscles. And the answer to that is the Crede maneuver, which you kind of press on the stomach and push on the bladder to help begin the flow of urinary continence. Apply gentle manual pressure to the lower abdomen. All right, and since the bladder muscles will not contract to increase the intrabladder pressure to promote urination, the process is initiated manually. And to promote continence, the bladder contractions are required for habit training, bladder training, and increasing the tone of the pelvic muscles. Training and Kegel exercises are not a benefit of the muscles that are flaccid. All right. Question 3. The nurse caring for a client in the spinal shock phase following a spinal cord injury appropriately plans to insert Foley catheter to accurately measure output, stimulate voiding using Crede method, assess for urinary tension with each voiding, and catheterize with a straight catheter every 3 to 4 hours. And the answer to that is, this really wasn't specified much in your reading, so I will give you the answer, and it's to catheterize with a straight catheter every 3 to 4 hours. You're probably asking, isn't that a way in which we would have a higher chance of introducing bacteria or some organism into the urinary system? It's better than having a Foley in continuously, which will definitely lead to urinary tract infection. Catheterizing the client every 3 to 4 hours with a straight cath prevents over-distension of the bladder and the increased risk of infection associated with indwelling catheter. During spinal shock, the bladder does not empty in response to stretch or other reflexes. Measuring residual urine is not indicated for this client. Output is measured when inserting a straight catheter. So that's the rationale behind that. All right, question 4. An older female client tells the nurse she is unable to maintain continence after she senses the urge to void and becomes incontinent on the way to the bathroom. Which of the following nursing diagnoses is most appropriate? Stress incontinence, reflux, functional, or urge. And that fits the definition of urge incontinence. Very good, everyone. I know you got that one right. And the key phrase is the urge to void. Stress incontinence occurs when the patient coughs, sneezes, or jars the body, resulting in accidental loss of urine. And reflex is the absence of control, and functional is the involuntary loss of urine related to impaired function, primarily cognitive function. Okay, 5, the nurse recognizes that urinary elimination changes may occur even in healthy older adults because the bladder distends and its capacity increases. Older adults ignore the need to void, and urine becomes more concentrated, and the amount of urine retained after voiding increases. Which one do you think it is? And the amount of urine retained after voiding increases. So that's the answer, and let's read about that rationale. The capacity of the bladder may decrease with age, but the muscle is weaker and can cause urine to be retained. Older adults do not ignore the urge to void and may have difficulty in getting to the toilet in time. The kidneys become less able to concentrate urine with age. All right. Good job with that, everybody. I'm very proud of you. It's nice to work these through together. And again, these have been uploaded in your Canvas course, so you can review these again. Very similar to what will be on your test over this material. All right, we're going to continue with part 2 of week 2, day 1, with STIs, or sexual transmitted infections.